So now I'll invite Dr. Parul Singh. She is Associate Professor at Kanpur. She'll be talking about the most important aspect of this pharmacodynamics, that is the aspiration. Because now the machines, initial machines, the basic machines were more of an energy based. When we started learning, the maximum vacuum we could set on a machine was 120 or something. And that was the reason we used to have more wound burn. The energy was used at 100%. And in fact, when I was starting learning, I mean, the cutoff time was 3 minutes of phaco time, 1.5 minutes of phaco time. So now which has reduced to few seconds. So the aspiration has improved over a period of time. So the fluidics is the most important part of understanding this machine.
Yeah. Thank you, sir. Thank you so much for the opportunity, sir. So I would be talking about the fluidics part of the pharmacodynamics and how we have to control the surge. So what is fluidics? Fluidics is basically an integrated function of infusion and aspiration of the fluid. And the advantage of phacoemulsification over the previous conventional surgery is basically that phaco is a closed chamber surgery. So it is the understanding of the fluidics that basically helps us to maneuver through the normal phaco and also the difficult and the complicated situations in the phacoemulsification. So to understand fluidics, the basic factors, so basically the fluidics means whatever is inflowing, that is the infusion, the fluid that is coming into the interior chamber, and the outflow, that is the fluid that is exiting the eye, the anterior chamber. Now this inflow will be through the bottle, the fluid is coming, and outflow will be through either the normal outgoing, that is through the tip, or through the wounds which we have created in the form of main ports and side ports. Now through tip, the outflow of the fluid will depend upon 3 factors which we will discuss subsequently. One is the vacuum, which is the holding power. One is the flow rate, that is how fast things happen in the anterior chamber, the fluid leaving. And another thing will be the compliance of the tubings. So first talking about the inflow, we just said that inflow, basically the fluid infusion is coming through the bottle, and height of this bottle basically determines the gradient of the flow. So this infusion is gravity dependent. For example, a 2 centimeter bottle height would result in around 44 millimeters of mercury. Similarly, 100 centimeters would cause a 74 millimeter of mercury in the IOP. So safe height somehow lies between 60 to 90 centimeter, or we can say 3 plus minus 1 feet. Now, the amount of fluid which is entering, if we increase the amount of fluid which is entering the eye, it will rise the intraocular pressure. So the bottle height has to be adjusted in such a safe way that the IOP is also at the safe level and we have a stable anterior chamber. So if we have increased the height too much, what it will cause, it will basically stretch the zonules and the patient will feel the discomfort because of too much rise of the intraocular pressure. If the IOP is too much, so a slight withdrawal of the fluid will cause very high IOP fluctuations, which is again not a good idea for the tissues. Another thing is, if there is a lot of fluctuation in the iris because of a lot of fluid coming, it can lead to meiosis and the pupil will become small and the surgery will become difficult subsequently. Also, if too much fluid is coming and we have larger wounds, if we do not have a very good wound construction, it might lead to repeated iris prolapse. So that is what we have to understand when we keep a bottle height. Now, the another thing, now we have discussed the inflow. Now the main thing, the aspiration system is the main part of the pharmacodynamics here. So as we discussed, it will be vacuum, it will be flow rate, and subsequently we'll discuss compliance and followability, etc. So first to talk about vacuum, what is vacuum? Vacuum basically is the holding power and it is generated by the machine. So vacuum is the measure of the strength of the hold of handpiece over the nucleus. So vacuum is basically a double-edged sword, and why do I say so? Because the settings of vacuum basically we have to keep changing, and what setting, how much vacuum to be used where. For example, if we are holding nucleus or we are holding cortex, so the settings of the vacuum will change. We would need more vacuum to hold on to the nucleus than to the cortex. Similarly, the vacuum is being transmitted either through the phaco tip or it is being transmitted through the inspiration-aspiration cannula. So, so this is how we have to understand when to use how much vacuum. Now coming to flow rate. Now what is flow rate? Flow rate, the term means the amount of fluid which moves out from the eye per minute. So flow rate basically determines how fast the things will happen in the interior chamber. So it is very important to have a good understanding of the flow rate. But to understand, flow rate is basically for peristaltic pumps, the flow pumps, and not for the venturi, because in venturi it is the part of vacuum itself. So in peristaltic pumps, as we have discussed earlier in the talk, so the flow rate is basically a determining factor in peristaltic pumps. Now flow rate is set for standard tips and tubings and fluids. For example, if we have a small bore tip, so the flow rate will be less because less amount of fluid will go out of the eye. Similarly, if lens matter is coming out, or the viscoelastics is coming out through the tip, so the flow rate will be less effectively. Similarly, if we have less elastic tubings, the flow rate will be less. So in earlier machines, the vacuum was only up to 120, and gradually when the machine generation improved and we had better settings and better dynamics, so the machines from first, second, third, fourth generation, the vacuum increased from 120. Now we are operating at more than 450 millimeters of mercury also. Similarly, flow rate in the earlier machines was only up to 20 to 24, and gradually with the advent of modernization of the phycodynamics, the flow rate has now increased from 30, 36, and even now we are working on 40 cc of fluid as flow rate. Now there's a term called rise time. What is rise time? Rise time is basically the time which is taken to reach a preset maximum vacuum after occlusion of the suction port. So if you see in this figure, in the venturi machines, if you see, there's a sharp, fast and linear, and because what is happening, venturi machine only it is the vacuum, so the vacuum is directly there on the tip all the time. So the rise time, that is the time to reach the preset vacuum, is short, and it is fast and it is linear. But in peristaltic machines, reaching a rise time, it depends upon the flow rate, because flow rate basically decides in the peristaltic machine that how things will happen. As you see, P1, P2, so P2 the flow rate is higher, so we get a sharper curve, and the rise time we reach earlier. So higher the flow rate, earlier we reach the rise time. Aspiration systems have been covered, which are like venturi and peristaltic. We have discussed venturi is based on Bernoulli's principle, where a compressed gas creates a negative suction in the cassette, and that is transmitted to the tip. But in venturi, we can control the vacuum, that is, we can increase or decrease the vacuum, but flow rate is proportionate to vacuum. It's a fixed fraction of the vacuum. We cannot independently set flow rate and vacuum in venturi pumps. Peristaltic pumps we have discussed, basically silicon tubing rolls over the wheels, negative pressure is created by squeezing of this fluid, faster the rollers rotate, more fluid is withdrawn, and therefore higher the flow rates. That is how, what I was talking before, the flow rate is basically function of the peristaltic pumps. So in peristaltic pumps, vacuum is used to hold the lens material, and it is the flow rate is basically, flow rate determines followability and rise time. And what is followability? We'll just discuss in the next slide. So it's important to understand followability. So followability is a term which tells us about the tendency of the nuclear material to come into the tip. And so how does it happen? So as we know, that is infusion, when the fluid is coming, the fluid coming inside the eye, it causes a positive pressure. The fluid that is going out through aspiration, it creates a negative pressure. Now this gradient bit of pressure which happens between positive and negative pressure, it creates a pressure gradient, and this pressure gradient, they form certain eddy currents in front of the tip. Now when this eddy currents, they help the nuclear fragments or whatever is there, everything that comes near the tip, and that helps, right? So in this picture, if you see, there is a green area near the phaco tip. This is the area of good followability, right? So in this, whatever will be in this area, that will easily come through the tip, a good area of very good followability. Now if you see the area of main port and the side port, which is shaded gray, this is the zone of no followability, because whatever, if a small piece gets stuck in these ports, it will not come itself. We'll have to maneuver it through the second instrument. And the green area you see in between, that is the zone of poor followability. So in that area, we can shift our phaco tip handpiece and we can bring out the pieces. So in nutshell, in the fallibility in venturi system, since the vacuum is generated even without occlusion, so the pressure gradient is high, fallibility is very good in the venturi system. Now in comparison, in the peristaltic pump, since there is no negative pressure at the tip until occlusion happens, the gradient of the pressure is poor, so the fallibility is relatively poor as compared to the venturi pumps. But if we increase the flow rate, the fallibility can be improved, right? So to have a better, what we do, size of nuclear pieces we always divide nuclear pieces into small pieces. Now these small pieces will have better fallibility. So this emphasizes why we should make into small pieces before we suck them. So, and I've already discussed, if the pieces are lodged in the angle or the capsular furnaces or in the main port in the side port, these are the areas of the poor fallibility. So this was about the fluidics. Now another part of this presentation is about the surge. So to understand what is surge is basically sudden withdrawal of fluid from the interior chamber. So a certain amount of surge is okay, but if that surge increases beyond a particular limit, it will cause the collapse of the interior chamber. And we do not want the collapse of the interior chamber because it will be detrimental to the structures inside, iris, cornea, PC. So basically, it is the modification in surge control which has taken phaco to where it is today, a better and a safe surgery. So if there would have been no surge, anybody could have mastered the phaco emulsification. So basically it is a surge control which is now so good in the machines and also as the surgeon experiences. Now the surge basically depends upon the two things, and we'll understand in the next slides about compliance and hysteresis of the system. What is compliance? Compliance is basically the property of the tubings to collapse, that is deform under pressure. So the extent of collapse will depend on three things. One is the size of the lumen of the tubings, one is vacuum, and one is the thickness of the tube. So the lumen size, if the size is more, so the compliance will be more. If the vacuum will be more, the compliance will be more. But if the walls are thick, the compliance will be less, right? And what is hysteresis? The hysteresis is the term which is used. It is a speed with which the collapsed tube regain their normal shape. So the regaining of the normal shape of the tubings, it depends upon the hysteresis of the material. So higher hysteresis means slower the speed of reformation and less the surge. So this is the concept of compliance and hysteresis which we should know before we understand surge. So in this diagram I'm just explaining, as you see in picture, the first, you have a piece and we have this peristaltic pump rolling. When you see in the second, when we come down, there is occlusion at the tip. So when there is occlusion, the vacuum will build up, the rollers will stop moving, and there will be development of the negative pressure in the tube, and the tubes will collapse, right? Now, subsequently, when the occlusion will break, there will be release of the negative pressure. The tubing will re-expand to its original size, fluid will be withdrawn from the interior chamber, and surge will happen. So this is how surge happens in the interior chamber. So the basic thing now basically is to understand how we can control this surge. Controlling surge is all we want to do when we want to do a safe phaco emulsification. So there's two ways to control surge. One is by the machine, all the modifications and advancement in the machine, and another thing is how the surgeon can control the surge. So we'll take one by one how the machine will prevent the surge. So the first thing, which was earlier in the machine, the one process is venting. So as you see in this picture, we have a piece, then we have a peristaltic pump, and you see a valve. So right now nothing is happening here. Now you see when there is occlusion of the tip, the tubing has collapsed, and we can see the vent is still closed. Now what happens subsequently, when the occlusion will break, the tube will expand, and now you see the vent is open. So what this vent is doing, it is supplementing extra fluid to the system. So there is a sensor in the machine so when the occlusion happens, the machine senses that there is occlusion, and the vent will itself, this valve will open, it will gush amount of fluid, the extra fluid. Now this extra fluid will take care, and there will be no collapse of the anterior chamber, and so we will have minimal or no surge. So this is the process of venting which machine uses to prevent surge. Other thing is, when we deal with tubings, modifications we can do at the level of the tubings is we can use a large diameter tubing for irrigation, and we can use a small diameter, thick and hard walled, that is a high vacuum tubings for aspiration. So the use of these tubings will definitely reduce the surge. And now, as we know, in modern machine, after third generation phaco machines, the tubings have been replaced by the cassette, which is again the machine that's how controls the surge. Now another modification, the machine came by the Star Surgical in the form of cruise control. Now in cruise control, what happens, this is basically we are improving the aspiration system. What we do in this, that we basically limit the exit of the fluid. How? There is near the aspiration tubing, we have a fluid restrictive exit after a cylindrical mesh, which restricts the exit of fluid without affecting the removal of the cataractous material. So in this way, less amount of fluid is released, so the machine has smartly controlled the exit of fluid and has very smartly controlled the surge. Now next modification came by the White Star, which is caused the chamber stabilization environment case. So what happens in this, the machine, when occlusion happens, the machine senses this, and it decreases the vacuum. The machine senses that the occlusion has occurred. So what happens is the phaco power, which is activated to occlusion mode setting, and then it defaults back to unoccluded mode settings, and there will be a down threshold of the vacuum, and so there would be limitation of the surge. Now so basically case technology allows the surgeon to operate in a new performance zone while they only break occlusion from within the comfort zone. Next came the advancement of active fluidics in the Centurion system by the Alcon. So again, they have dual sensor in irrigation as well as aspiration, so have a definite advantage over the gravity-based fluidics which was used in the previous machine of Infinity. So what happens in Centurion? The machine senses, it steps down on the vacuum before the occlusion breaks. So this active fluidics, this fusion fluidics, it maintains the interocular chamber, improves the chamber stability by control of the target intraocular pressure. So it is a very, very safe system which has been developed in the Centurion, and it takes care of the surge. We almost have no surge in these advanced machines. So this was how the machine will control the surge. Now we will discuss what the surgeon can do to control the surge. So what is in our control as a surgeon is, first is the infusion. So we can increase the fluid into the anterior chamber. How? We can increase the bottle height. We can use the TER set, the improved tubing sets. Then we can use the anterior chamber maintainer if we wish to, or we can do the surgery in continuous infusion mode. So this is how, with the help of the infusion, we can control the surge. Now second thing to control the surge is to make a very good wound. So wound construction is of paramount importance in the beginning of the surgery, both main ports and side ports. So main port, it should not be too tight. Or what will a too tight main port do? It will restrict the amount of fluid also, so it will somehow restrict the good inflow of the fluid. It shouldn't be too loose. It shouldn't be a premature entry. Too loose main ports and side ports will leak will cause a lot of wound leak. It is not a good idea. It will augment the surge. Similarly, premature entries, it create a lot of problem, lot of fluid leaks. Every time we enter and exit with the help of our handpiece, a lot of fluid is withdrawn, and so it causes surge. So adequate wound construction is of paramount importance. When it is in our hands to make a good wound, less surge. Now the third thing in surge's control is to decrease the effective flow rate. So how can we decrease the flow rate effectively? First thing, we can use a micro tip a small bore tip means less amount of fluid withdrawn, which means we can keep the flow rate lower. So lower flow rate, less fluid withdrawn, less surge. Similarly, we can increase the viscoelastics in the interior chamber while using our steps. Increased viscosity, because of increased viscoelastic, it decreases the effective flow rate. Similarly, the third thing which we can learn, which we do, is the partial occlusion of the tip. What does that mean? When we have occluded the tip with a piece, before we take it up by, and this is in our foot control. So before we remove this occlusion, what we can do is very swiftly, we can partially occlude the tip with another piece. So we are not breaking, after occlusion, we are not breaking this cycle, and before the occlusion breaks, we are partially occluding the tip with another piece. So this is how we can decrease it, we can effectively decrease the flow rate. So basically, all this happens when we have a good foot control. So as the experience comes, the proficiency of FACO we learn. So basically it is a foot control. So when we have a good foot control, we can maneuver all this, where to keep the foot before the occlusion breaks and how we can control this. So this is all I have to tell about fluidics and surge control. Thank you so much.